So this morning for Grand Rounds we have two excellent talks coming up. The first is by Dr. Edward Jones on operating room fires. And by way of a brief introduction, Dr. Jones is an assistant professor in the Geitz Division. He spends his time at the VA, did his undergraduate training at Harvard, and then went to Case Western for medical school, and is probably responsible for the pipeline from Case Western to our general surgery residency. After doing residency here, he did something relatively unique for general surgeons. He went to do a flexible endoscopy fellowship at The Ohio State and returned here for his faculty position. Now, he's one of a few general surgeons in the country that has an expertise in endoscopy to the level where he routinely does ERCPs. And I just want to remind you that the very first ERCP was done by a surgeon, Dr. McCune, in 1968 at Northwestern. Eddie's been on the faculty for 2.5 years now. He already has about 30 publications and has won grants from organizations such as SAGES. The other thing is I was here for a good part of his residency, and he managed to win almost all the major awards during residency, won the Eisman Award, won the Owens Award. He's really on his way to a terrific academic career. And Eddie, thank you very much for coming and giving this talk.
Thank you, sir. All right, thank you, Dr. Schulich and the Department of Surgery for the opportunity to present today. And first, before anyone else asks, yes, I did get some sun this weekend. I wanted to demonstrate really my true dedication to avoiding burns by obtaining one myself. But moving on to operating room fires. This is an area I've had the good fortune of doing some research in with Dr. Tom Robinson and several of the residents here, Brandon and Doug, Heather Carmichael, and so on, to really kind of help us define what our risks are. And so I have 4 major objectives today. First, we'll focus on defining what exactly is an operating room fire. And this is a little more tricky than we all would guess. I think in our mind's eye, we're picturing these large yellow flames reaching up to the sky, kind of like a campfire. But it turns out, if you really kind of drill into the Joint Commission guidelines, that it's actually a little bit more complicated than that, and that becomes very important when we're identifying the incidence of fires. And we'll look at some of our own data that Doug Overby published in JACS that I think helps cement this idea that the incidence of operating room fires, not only because of the changing definition, but also because of our increased dependence on surgical devices, is increasing over time. So it's becoming more and more important to be aware of this. And then really we're going to spend the bulk of our time looking at how do we prevent these, because really it's all about risk reduction. We should be able to completely prevent operating room fires. And then finally, what happens, catastrophe, that fire starts in our operating room, what do we do? So this is kind of what I pictured when I first thought about operating room fires. And then I just kind of moved that into more of a surgical setting, so some nice blue towels. Maybe I'm activating the energy device and kind of whoosh, this little flame comes up. Maybe it expands, maybe there's yelling and screaming, fire, and whatnot. But most of our fires these days are alcohol-based fires. They're this nice kind of almost hard to see blue flame. And you can imagine as you drape out the field, it can be very, very hard to identify these. And the longer this small flame that may be on the drapes alone is burning, the more likely it is to turn into a true catastrophe and result in major injury to our patients. But even more so than that, if you really look into the Joint Commission guidelines, you look into their manual. So it's going to define fire in this way. This chemical reaction, evolution of latent heat, okay, that makes sense. The second sentence, however, a smoldering condition without flame is also considered a surgical fire. And so I had a personal experience with this when I was in fellowship. I had no idea that this was a big deal or this was the definition. So I disconnected the light cord, attending was already out of the room. I was operating on my own, set it on the drape, nowhere near the patient, and there was a hole in the drape. The nurses noted it, got reported to Joint Commission as a sentinel event, because this is a surgical fire. I had to go to risk management. Again, no patient injury, just a hole in the drape. And I think when that first happened, I was like, what the heck? This is very, very aggressive. But as we're going to go on to look at the impact of different ingredients in the surgical fire triad, this small, tiny burn can result in a catastrophe very, very easily. And then also, please keep in mind the panel on your bottom right, that is from accidentally leaning against a bovie. So the bovie's not in the holster, you're leaning, maybe reaching, retracting, whatever you're doing, and you're getting a small hole burn. That is also considered a surgical fire. So if we think about that, all of a sudden, these are happening much more frequently than we think. But if we go back to before the Joint Commission really truly defined this, back to 2009, this is the best data we have from the Emergency Care and Research Institute, looked at a database in Pennsylvania. And they extrapolated it out through the entire U.S., and they estimated about 500 to 650 events per year. Now, these are your real big flames fires. And this results in 2 to 3 deaths per year. And this was back in 2009, before we had a ton of these surgical devices, many of which create a spark. And then we looked at our own data. Doug Overby published this in JACS a few years ago now, looking at the MAUDE database, the Manufacturer and End User Database Experience, or MAUDE. Essentially, it's a voluntary database where anytime a surgical device goes wrong, you can report it voluntarily, and they'll look into the causes. And these are the specific reports related to fires. And you can see there's a sharp increase in 2015 and 2016, and we are unable to drill down exactly what happened. But I think this, in addition to every conference that we go to, where there's a plethora of surgical devices out there, increasing every time, just goes on to emphasize that the incidence of fire is only going to go up. And so our focus on prevention needs to be even greater. So what's the big deal? There's a small hole in the drape. Well, this is a very, very famous case, 2011 out of the state of Washington. A very young woman went in. She was having MAC local to have this tiny mole removed from her face. And this happened. And so I think this does a nice job of emphasizing, even though it is very rare, it can be devastating, not only to the patient, but think about how the surgeon reacted to this. None of us want our patients to be injured. Think about how the whole operating team reacted to this. The nasal cannula melted in her nose, causing some minor airway injuries. So anesthesia, of course, is involved. The operating room team is all involved. And then this went on to impact not only that small group of operating room personnel, but the entire hospital system. Additional training, additional requirements, and so on. And so these small little events that I'm working to prevent today, those small little tiny flames, those burn holes from the fiber optic cord, those are actually very important because we want to avoid this severe event. And so how do we prevent this? Let's really get into the meat of what you and I as clinicians can do every day to prevent these. And to do that, we have to go back to maybe middle school when we learned about the 3 ingredients to create a fire: a fuel source, a heat or ignition source, and an oxidizer. In our operating rooms, the most common oxidizer is oxygen. Nitrous oxide is also very good at this. So obviously very prevalent. Fuels, alcohol-based skin prep, something I had the, like I said, good fortune of doing a decent amount of research on now. But drapes, gowns, gauze, the patient's own hair and tissue can all serve as fuel for the fire. And then finally, our heat source, 90% of the time, it's that handheld electrosurgical device, the bovie, as we so lovingly call it. But lasers, fiber optic light cords, even defibrillator pads can actually increase temperatures enough to ignite a surgical fire. So let's kind of take these one at a time to really drill down into what we can do. So this is a very nice article published in Anesthesiology 2011, looking at closed lawsuits with regard to surgical fires. And what they identified was that the vast majority are happening in the head and neck or upper chest. And the vast majority are happening under monitored anesthesia care. And so the assumption here is that it has to do with oxygen. And I think that's an excellent assumption. So if you look at supplemental oxygen, nasal cannula or mask, even at low airflow rates, 4, maybe 3 liters, you're creating a local increase in oxygen content. You can see it there in the red of about 5%. You turn it up to high flow. Now, what I think is not all that bad, but 5 liters, maybe 6 liters, you're getting a local increase in oxygen content 35 to 50%. That's on top of room air at 21%. You do some fancy draping, and I really hope that this wasn't an actual case, this draping here, that they were operating on the head and neck. But if you do something of that nature, now you're trapping all that oxygen, and you're going to get massive increases in the local oxygen content. Well, why is that important? As I'll show you in just a second, if we increase that local oxygen content right where you're operating, where you're activating that energy device, much more than 30%, you're going to take things that aren't normally flammable, and you're going to make them flammable. And this is a great article by Bill Culp out of San Antonio, who looked at exactly that. He took common things, your sponges, your utility drapes, your gowns, and he spread them out nice and flat. He clipped them into a nice clear box, and he dialed up the oxygen, and he put a flame underneath it. So this wasn't like a real OR scenario. This was an actual flame held up to these things. And he looked at, could we light them on fire? So let's look at ignition time in room air oxygen, 21%. Your standard utility drape, your gowns, they're not flammable. They're not lighting on fire. These other things are flammable, but it takes, about a second for them to light. And again, this is a direct flame exposed to these things, so a little bit of an unusual circumstance. But I think it really proves the point that as soon as you start dialing up that oxygen content, these things ignite very, very rapidly. And if you look at burn times, take your blue operating room towel, your standard blue towel. It takes about 21, 22 seconds to burn in room air. You dial it up a little bit, cuts it by a third. Now it's taken 7 seconds. And you can see on the far right, everything's burning in 2 seconds or less. And so this really emphasizes the massive impact that supplemental oxygen has on the fires, and this will play into what our first step is when an operating room fire does break out. So I think this is just a little better visually represented. I know those dots are tiny, but essentially on the left side of the screen, burn time, how many seconds it takes for that to burn. As it goes up, obviously that's better. And then on the bottom, as you move towards the right, your oxygen content leading up to 100%, and you can see this massive downward trend. So as soon as you really start dialing up the oxygen much more than room air, you see all of these things burning very rapidly, 10 seconds or less, 5 seconds or less as you get closer to 100%. So what can we take away from this? What can you and I do? Well, I think, this doesn't always have to be said, but I'm going to say it today. We really want to use the lowest and safest oxygen content for the patient. And so if we're in a high-risk area, what's high risk? So that's head and neck, or you have the supplemental oxygen going, or both, of course. Well, maybe if we have to use energy in that area, if we're going to use an ignition source, maybe this is a patient, even though patient doesn't necessarily need the ET tube, but maybe we should do that. Because we don't want, like you saw that picture of the patient out of Washington State, we don't want that surgical fire. If you are going to use an open oxygen system, we need to make sure right where we're operating, the oxygen content in that area maintains less than 30%. And we can avoid this by creating pockets. You can do an open face draping technique where actually the face is open, and even though you got supplemental oxygen, maybe you're working on the neck or what have you, all of our ORs are mandated to do at least 20 exchanges of air per hour. And so it'll very rapidly dissipate supplemental oxygen that you're giving, unless you trap that with your drapes and bring it right into the field where you're operating. And then, please don't forget that steel is not flammable. And so just don't use the energy device. Speaking of energy devices, by far and away, the most common way to ignite a fire is to use that handheld Bovie. Whether or not you're intentionally creating that spark gap, intentionally creating that brief kind of arcing of energy, that's really our highest risk time. And so we need to stay focused on only creating that spark gap when we intend to create that superficial burn that is achieved by that extra distance. Lasers, of course, used much more rarely, but they can ignite a fire, light cords, and so on. And so what can we really take away as clinicians? Well, we just need to be selecting the lowest risk device for the procedure that we're doing. So it doesn't get much higher risk than putting in a trach. You have a patient, you can't really dial down much less than 50% or 40% FiO2, and so you're going to have oxygen coming straight in. So either turn it down right before you make your incision, or if you're going to have the oxygen content increase, then use steel. But what happens? So you get into some bleeding. Can't really see what's going on. And so I don't think any of us are going to reach for the APC to try and put this out. Not only is it a massive risk for fire, but it's not an appropriate device for the situation. We're much more likely to select a more appropriate device. Maybe a bipolar device, maybe an ultrasonic device, which are low risk. You're not seeing a big arc. Or maybe even just the old-fashioned suture to help stop this bleeding. And so we have to be cognizant of the fire risk when we're approaching these high-risk situations. All right, so really our goal is to reduce this risk to prevent these fires. So we've talked about oxygen, we've talked about heat sources. Let's move on to our alcohol-based skin preps. We've already kind of learned just how flammable our gowns and drapes are, which is not very flammable, again, unless that oxygen content is increased. So fuels, this is an article I was able to publish with a bunch of our team here last year. And we wanted to define two things. Number one, is it the alcohol in the alcohol-based skin prep that's flammable? Because that actually hadn't been proven in about 30 years or so. We thought it was true, it makes sense, but it's never really been proven. And then number two, we wanted to identify what you and I can do if we had to use an alcohol-based prep to decrease the incidence of fire. And so I think what is not surprising to anyone is the non-alcohol-based preps, your plain chlorhexidine, your iodine, you can't light those on fire. And so what we did was we took about a 25 square centimeter piece of porcelain skin, you'll see a picture in a second, and we prepped it, and when there was no drying time, we essentially just activated a bovie for about 2 seconds. When there was 3 minutes of drying time, we tried to wait the full 3 minutes and then activate it as well. What we were also a little bit more surprised to find is that in 1 in 4 cases, we could light a fire with no prep time using these alcohol-based preps, and we used several different ones. And even after waiting 3 minutes, even after listening to the manufacturer, tapping our foot in the corner as we frustratingly waited for that drying time to expire, we still lit a fire 1 in 10 times. And these weren't just tiny little fires, as you can see up in the left. Maybe you've seen this, a little kind of a poof right around the tip of your bovie and it's gone. These are real fires, as you can see in panel C, spreading fires that spread across the tissue and would result in serious damage to the patient. And those are just thermal image confirmation on the right side there. And so then we wanted to take this one step further, like I mentioned. What can you and I do as clinicians to decrease this risk? And we thought, well, let's look at pooling, because everyone's prepped around the belly button. There's a little puddle there. And I used to think, hey, maybe that little puddle of extra prep, maybe that got rid of some of the bacteria we couldn't kind of scoop out with the little cotton tip applicator. But it turns out that that is absolutely the highest risk situation, especially with our ChloraPrep. You can see the numbers there, and they were startling to me when we published the paper. So no pooling, 10% after trying to do this right after you prepped. If there's a pool present, we couldn't not light a fire. 19 out of 20 attempts, we could light a fire. Even waiting 3 minutes, if the pool was still there, 75% of the time we're lighting a fire. And so we have to avoid these little pools. Before you even grab the bovie, make sure you get rid of any of these pools of prep. And keep in mind that when you square off that drape and the pool kind of trickles down on the side, there could be a pool of prep underneath the drape as well. And so not just the umbilicus, not just skin folds, you got to keep in mind the entire surgical field. And so what I really wanted to say in that paper was, please don't use alcohol-based skin preps. Unfortunately, a very powerful group called the CDC came out in 2017 and said, we recommend alcohol-based skin preps for the reduction in surgical site infection. Based upon relatively decent data, some of it industry-sponsored. I'm a little biased, I admit it. But I understand it does reduce infection risk in particular cases. But if you're in a low-risk situation, low risk for infection, high risk for fire, let's return to the head and neck again, maybe we shouldn't be using these alcohol-based skin preps. Let's take away one of those pieces of the fire triangle to really reduce our risk. I also want to mention that this 3-minute dry time, it appears to be ineffective in preventing fires. I am not saying don't do it. What I am saying is you can't trust waiting 3 minutes to take away your risk of igniting a surgical fire. And so you still have to pay attention to everything else that is going on and make a fire risk assessment, which I think all of us are now doing as part of our timeout. And we'll go into a nice example of one in just a second. And then finally, avoid the creation of pools. So a fire risk assessment. This is a very, very nice device, and I think it does an excellent job. We do it in our timeout at the VA of helping us all define whether this procedure itself is high, middle, or low risk for fire. And you can see kind of this is a more robust one developed out of Springfield, Illinois, after they had a catastrophic fire event. There are several things that all of us could be doing in every single case. If you look under intervention, bovie and holster 100% of the time when not in use. I think that's very logical. If you're taking away the ignition source, the accidental ignition source when you're leaning across the table, you're taking away this possibility of igniting a fire. Turning the fiber optic light source off so you can't burn a hole in the drape or ignite a fire in that manner. And if you are going to have high risk, one of the things down at the bottom there, you can see it says saline soaked sponges available. And so you have a tiny little fire. Rather than trying to reach down and pat it out rapidly with your hand, if you have a saline silk sponge available because you know you're high risk for fire, you can just grab it, put it out. Done deal. So I think we've nicely kind of worked our way through the first three of these. What happens if we start a fire in the OR? And I'm not talking about just something you can rapidly pat out. What if this is starting to become a big deal, and it only takes less than a second for it to become a really big deal? Number one, stop the flow of airway gases. Disconnect the breathing circuit. I showed you in a couple articles just how important that increased oxygen content was. Your fire starts on the drape that's protecting your MAC oxygen content from where you're operating. As soon as it burns through that drape, it gets right next to that increased oxygen content, and now you have this massive fire. So number one, as soon as you see it, you got to be talking to anesthesia. Disconnect the airway. What if the airway's on fire? This actually used to happen not frequently, but more frequently when there was more lasers in use when you were doing head and neck surgery. The endotracheal tubes aren't perfectly resistant. Even the reinforced endotracheal tubes that have those nice metal coils aren't perfectly resistant, and they were burning into it with the laser and igniting things on fire. So what if the airway's on fire? Pull it out. You got to get rid of that. You got to get rid of the fire and the oxygen source and pour saline down there. This is our first step. We got to be communicating with the team. We got to say, hey, there's a fire. Let's get rid of any oxygen. After that, what are we going to do? Well, if it's very, very small, you can pat it out and be done. But if this is starting to become a real fire, what you got to do is you got to remove all of this burned stuff from the patient. You got to remove this kind of constant collection of stuff that is injuring our patient. Don't grab a heat blanket. That's been done in the past. Put it on top to try and snuff the fire out. All that does is contain all that heat and worsen that injury. Yank all the stuff off the patient. The time to think about sterility is gone. You got to protect the patient from a catastrophic injury. Extinguish that stuff on the ground. And keep in mind that it may take a decent amount of saline or water or whatever you have handy. Very rarely do you ever have to use an extinguisher, but by all means use it if you need to. It can take a lot because all of these devices are designed to be water resistant. They're designed to make it easier for us to do surgery, and so it's going to be hard to put them out. And then finally, restore the breathing and start caring for the patient. All of this in a well-trained team takes less than 5 seconds. There's some nice virtual reality simulator stuff that's done at SAGES every year that proves that when you and I know the steps, we can do this so rapidly that the injury is minimal, if any. It's like a sunburn, for example. And so I think the key is really using our knowledge base and being prepared for this catastrophic event. So I just got to say it one more time, the key here is prevention. This is a never event. This should not happen. All right? We need to avoid creating local oxygen content greater than 30%. We got to avoid heat sources in high-risk environments that create sparks. Choose a different device. Use an ultrasonic device. Mechanical energy just vibrates back and forth. There's no spark there. Use a bipolar device that's much more contained in a high-risk situation. Then fuel, of course, as I already mentioned, avoid alcohol-based preps in appropriate scenarios, and definitely avoid the creation of pools. Thank you for the opportunity to present today. Any questions?
Questions from the audience? That's great. Question or two. So, Eddie, how often does this occur in a hospital, say the size of UCH, in a year?
So interestingly, I'm actually in the process of applying for an AEF grant, and so I was able to pull the data from our own institution. And something like this happens about 1 every 6 months. And I'm not saying the massive big fire, but I'm saying what is classified as a surgical fire. So the vast majority of our cases are inadvertent bovie activations or holes in the drape. So no patient injuries. But that being said, that carries a great potential for a bad injury.
Please. Warren.
Question for you in terms of light sources and some of the newer LED light sources for laparoscopic surgery. Can you kind of talk about some of the differences between maybe xenon versus LED versus something else that's out there?
Well, that's an amazingly advanced and complex question. So I don't know the real answer other than in broad appearance. So if you look at the standard fiber optic light cords that we have available that's most common, we actually put a thermal camera on one of those and looked, and it's about somewhere between 45 and 50 degrees, so very, very hot. when you're connected to the telescope. If you disconnect it, it's even hotter than that. Now, with regard to LEDs and the newer things, telescopes, theoretically the temperature should be less, but we haven't personally measured that yet. I haven't had access to any of that. So should be safer, but I don't know.
Yeah, I think the light source for LED is a lot less, but when you put all that energy through fiber optics and metal and who knows what, I think it still can reach a relatively high temperature. But LED should be safer. Anything else? Dr. Stigman.
Eddie, you're an endoscopist. What about the risk of shooting sparks around inside the colon?
Yes, so that's a great question. There was actually, I'm sure many of you saw it in the lay press, an incident in, I want to say Japan, of an explosion from a colonoscopy when someone was using an energy source. And so there are several factors that play into that. So one, we moved away from our mannitol-based preps because that increased the incidence or the amount of methane gas during colonoscopy, and we've moved more towards these standard go lightly and half lightly preps and whatnot, which reduce the risk of igniting a fire. That being said, the APC, which is, for those of you who don't know, that device that I showed when we were looking at the trach, that's an open flame, essentially. And so the goal is to really kind of collapse the colon around it, and then look at the lesion that you're going to APC and be suctioning at the same time as you're applying that device. And so there is a real risk. It seems to be more rare or less than our surgical risk because you're not using energy all that much. Most commonly, if you're going to do it, you're going to use a snare, and you're going to kind of wrap it around a polyp, activate the snare, and there's no arcing. So really, it's kind of the APC, which is the biggest risk device during endoscopy.
And I've actually seen a flame when somebody tried to enter a very distended colon, which obviously was full of methane. So I think that's a situation to be very careful in. Any other questions or comments? Okay, Eddie, thank you very much. This is a great review, a very important topic. Thank you.
Thanks, sir.